So this is going to be a short slide set on headaches, not intended to be all-inclusive, but rather to give you an outline of some things to look for as you do your reading. The first thing I want you to do is to review the American Headache Society slides on migraine and cluster headaches, because it's really quite good, and there's no sense reinventing the wheel. They have a great deal of information on their website too, so I would suggest you look at the American Headache Society website. There's a lot of good information. I'll refer to some of it in here, but it's pretty comprehensive. So review that slide set first and then add this on. So what will be added here is information on tension headaches, on headache warning signs, on headache prophylaxis, and avoiding some of the pitfalls and hazards of treating headaches. Headaches can be really problematic for many people and really cause a lot of misery in humans. Probably the most common kind of headache is a tension headache. It's the one most of us get at the end of a long, difficult day or when we're really stressed about things. It's often described as diffuse dull throbbing or like a tight band around the head. It can be experienced almost anywhere on the head. It tends to be symmetrical as opposed to migraines, which tend to be on one side or the other. It's sometimes accompanied by tenderness of the scalp, neck, and shoulders, and can vary quite a bit in intensity. Tension headaches can be severe. Not everything intense is a migraine. Among laymen, migraine is kind of a word for intense headaches. So when a headache's bad, someone says it's a migraine, but there are lots of other kinds of headaches that can also be very intense. It's usually not associated with an aura or nausea, vomiting, or neurological signs of any kind. The American Headache Society divides these into acute sporadic and also chronic. So acute sporadic is one type and chronic. The acute sporadic headache is the one most of us get periodically, and you treat it with standard analgesics. So usually some ibuprofen, some Tylenol, some Excedrin will usually take care of it pretty well for you. The problem is the chronic types, and there are people who really have chronic tension headaches and have them every day or every couple of days, and they're really hard to treat. What you want to do is to avoid the chronic use of analgesics, because this rapidly gets people into rebound headaches just as it does in migraine. So that they're using a lot of ibuprofen, and whenever it wears off they get a headache, and pretty soon that gets to be a vicious cycle and can be very hard to get people off of these. Sometimes they actually will bring people into the hospital, get them off of medications, even common medications, because they need some other medications to help them with headache while they get them off of it. The tricyclic antidepressants, particularly amitriptyline given at bedtime, are pretty commonly used for both tension and for migraine headaches, so I'll mention that. But if you have somebody who's got a chronic headache problem, sometimes it's worth a try. You do have to be careful with the tricyclics in relationship to making sure there are no cardiac problems that could be exacerbated by the tricyclics. Possibly other antidepressants will work. There is a link to serotonin in some of the research for both migraine and tension headaches, and so that is a possibility in both of those types of headache. And stress reduction often works well for people with tension headache. We'll talk a little bit more about this in a later slide. So let's think about the headache warning signs. These are things that require further investigation. Anybody with a new onset headache after age 50. This is a person who doesn't usually get headaches and now is coming in complaining of headaches, particularly regular headaches, because there's a much higher incidence of intracranial lesions of various sorts after age 50. This gets them an automatic new trip through the MRI machine. A chronic worsening headache is another kind of headache for which imaging would be appropriate. In most of these cases, the imaging isn't urgent, but you need to get some imaging on these folks to see if anything's going on. On the other hand, the next three, a new headache with neurological signs, headache that is abrupt and severe, the patient says it's the worst headache I've ever had, and a headache after closed head injury. concern for these is an intracranial bleed often, and rapid imaging is needed. When we're talking about imaging, look at the American Radiologic Society information that I posted. Their site has great information on what kind of imaging is needed for all kinds of situations, and it's often hard to know, especially when you're a new practitioner, is this something where I do better with a CT scan or better with an MRI or sonography, and they really will help you with that. So have a look at their site and their information on imaging for headaches. See what they have to say there. It's really helpful. Headache with fever and stiff neck, of course you're worried about meningitis here, and they need to be sent to the ER for a workup, CBC and LP, and usually some blood cultures. Those three that were above where I said you needed rapid imaging, either send them to the ER, or if you know someplace you can get them in for rapid imaging, that's acceptable as well. And then last, temporal tenderness over the temporal artery that comes with the headache. You need to rule out temporal arteritis, which is an autoimmune disorder, and you need a SED rate on those patients to see if that's a possibility. Okay, let's talk about headache prophylaxis. The first thing to start with is something called headache hygiene. Now, usually you're going to start with a headache diary, because what you want to do is see if you can help the patient associate symptoms with possible triggers, because it's not always easy to pick up the triggers. They could be dietary, it could be a certain combination of things, but a headache diary will really help you with this. The link here is for some headache diaries at the American Headache Society. So have a look at those example diaries that you could use for individuals with headaches. And I encourage people to keep them for a couple of weeks, and sometimes you get a lot of good information from that. Usually you're putting the symptoms on one side and your diet on the other side, and other things that have happened. Avoid caffeine. Caffeine in and of itself is not the trigger. Caffeine is often used to treat headaches, but rather withdrawal from it is the problem. So if you avoid the caffeine, you also avoid the caffeine withdrawal. So take all the caffeine out of the diet. Get adequate sleep. Regular exercise. I didn't put in here regular meals, but that's important because hypoglycemia in some people will trigger a headache. If you've ever gotten really hypoglycemic, you know a headache often goes with it. Some people are more sensitive to that. Avoid the triggers, and you've got to find out what the triggers are with the headache diary, but here are some things that are common triggers. Aged cheese, alcohol, red wine, chemicals, for example, MSG, caffeine withdrawal, processed meats containing nitrates, and nuts. Those are some common things. If you go to the American Headache Society again, you'll see their information for patients on headache hygiene. And it's a nice little summary here of some of the things that often cause headaches in individuals. Stress reduction will be important in headache prophylaxis. And again, we're going to talk about this in a minute. Here it is, right here. Consider complementary therapies. These are things with few side effects, and obviously the things you want to try first are the things that have the fewest side effects. See, you can treat it with a lifestyle alteration, among other things. We talked about that already, some of those avoidances. But here again we have things with few side effects. Nutritional supplements. Magnesium, feverfew, vitamin B2, riboflavin. There's actually some pretty good research on this. It's mixed, but there's some studies that show some pretty good effects from it. And some people feel that the difference in the studies is really related to the form of magnesium that's used and how well it's absorbed by the body. The one side effect of this is magnesium will give some folks diarrhea. Magnesium is used for a laxative, but in higher doses than usually give it here. Usually you're talking about 400 to 600 milligrams a day. If you want to avoid the diarrhea or laxative side effects, use a chelated form of magnesium like magnesium aspartate or magnesium glycinate. They're both also very well absorbed too, so that's another reason to use them. They're a little harder to find. You have to go to some kind of a supplement store of some kind in order to find those. But the headache clinics, a lot of them use these nutritional supplements, and there are some commercial products available that actually combine magnesium, feverfew, and B2 in them that are available that patients can try. Usually takes at least 6 weeks to see effects from this kind of therapy. Mind-body medicine, this would include relaxation, meditation, journaling. That can be really good stress reducers for folks and help them with some of these symptoms. Yoga also promotes a lot of relaxation for folks, and a lot of body therapy that really influences the mind and helps with stress. Acupuncture is another possibility, often effective for people with headache, and massage is another one. These things don't have many side effects. When you get to the medications, there are always side effects. Doesn't mean you won't use them, because there's a place for medication prophylaxis. You've got a patient with migraine and you've tried all the abortive therapies that are outlined in the other slide presentation, and those aren't sufficient even of themselves, or the person is still having a lot of headaches. The first thing you want to do is do the lifestyle headache hygiene things to see if you can reduce their incidence of headache along with some abortive meds. If those aren't working, then you're going to go to considering some medication prophylaxis. Probably the most commonly used one and an excellent one are the non-selective beta blockers. Propranolol, especially the long-acting varieties, Inderal LA is one of those, or the generic form as well. Or Timolol will usually work. There's more evidence on propranolol. It's been used longer, but there's also some studies on Timolol that shows that it works well too. It's also not a cardioselective variety. You don't want the cardioselective varieties of the beta blockers because they are actually formulated not to cross the blood-brain barrier to reduce side effects. And obviously, if you're going to have an effect on the central nervous system, you have to have one that does cross the blood-brain barrier. Side effects here include some sedation, although patients do get accustomed to it, and you can also start your propranolol low and gradually increase it as the patient develops a tolerance for it. You have to watch the heart rate as you increase doses of propranolol or timolol so that you don't get too much bradycardia. And patients may complain of exercise intolerance. This isn't so much intolerance as it is that they need a longer warm-up period because the beta blocker puts a brake on the heart rate. It takes longer for the patient to warm up and get their heart rate up. So you can usually help patients with this by telling them that they just need to take a longer time to warm up and they can still exercise. Amitriptyline, we mentioned before, is good. Most patients don't have a lot of side effects from this, some sedation, but if they take it at night, it minimizes the sedative effects of the amitriptyline and will still help their headaches. Depakote, Depakine, the anti-seizure medications, are used sometimes effectively as prophylaxis, and Topamax. With Depakote, Depakine, and also with Topamax, sedation is a side effect, and with Topamax in particular, patients complain that they feel kind of foggy. Their mental functions feel kind of foggy with it, and that's the biggest complaint. Here's a good article in American Family Physician on medications for migraine prophylaxis, so you can have a look at that if you want some help with that. Okay, avoiding the pitfalls of managing headaches. Be sure that you get a really good headache history, all the HPI elements. Everything you do with a headache is probably going to be more around your history than it is around your physical in most cases. Your physical, you want to rule out any neurologic changes, so you're going to do a neuro exam. You're going to check the temporal artery area, and if that's negative, which it is in most cases, you're really relying on your history to give you some important clues. So you want to know the the nature and character of the pain and the temporal elements that go with it and the location of it in their head and the timing of it, how long it lasts, if they can identify any triggers that go with it, ask about eating, ask about sleep. If it's a woman, ask about her menstrual pattern. So getting the really good history is really the key here. What makes it better? What makes it worse? Watch for those warning signs that I talked about earlier, things that you need to investigate further. Use the headache diary. Start with the lifestyle changes first, the headache hygiene elements, and consider the treatments with the least side effects first. Avoid analgesic dependence and rebound headaches because you can get real fast into this and it's problematic. Once a patient really gets dependent on some of these things, then it's really hard to get them off of it. Avoid narcotic, barbiturate, benzodiazepine dependence and use them very carefully. So that's the outline for you, and review the other materials, and then we'll take questions on the discussion board.